For interest of time, we had to move on directly, so I will call upon Professor Falconi from Verona in Italy. He's going to discuss surgery of neuroendocrine tumors for advanced disease. Please, Massimo.
Thank you very much, Professor Oberg, and good morning to everybody. After the philosophy and the nomenclature classification of neuroendocrine tumor, we are moving to the practical ground. And usually the surgeon in this setting is seen as a possible protagonist, but unfortunately in the advanced disease we have to follow different rules. Because if we look at the possible definition of advanced disease, it means that it's a disease not suitable for radical surgery because of the presence of the diffuse disease. It means that the disease can be located or just limited to the intra-abdominal setting, but on the other hand, we have to consider the possibility that the disease is also located in extra-abdominal setting. And so far, the philosophy of the surgical treatment becomes to have a possible role as palliation of mechanical symptoms, if any, or in the logic of debulking or site reduction. And the concept of debulking is quite wide in the literature. In the past, by the Murtaugh series, what was established as a definition of debulking was the resection of at least 90% of the burden of the disease. But we have to say that this is an old concept, because it was strictly related to the attempt to control hypersecretion when neuroendocrine tumors were diagnosed because of hormonal hypersecretion. And nowadays, there are some drugs, as you know very well, that are able to control symptoms much better rather than surgery. But there is nowadays another possible concept that we are going to try to explore. That is what I call oncological. That means to resect at least the primary tumor, aiming to try to solve or reduce the risk of mechanical symptoms. On the other hand, to try to reduce the burden of the disease in order to leave just one organ, if we are in the gastrointestinal and abdominal setting, and usually this organ is the liver, as well as to try to optimize the response for further therapies. However, if we try to find a general rule, it's quite difficult because, as you know, we have seen that we are dealing with carcinoma, definitely, because we are in the advanced disease setting. And in this setting, we are speaking both about or either by well-differentiated or poorly differentiated tumor. We have to consider different possible sites, and in this peak, I would limit my attention to the pancreas and to the jejunum, and on the other hand, we are dealing with clinically different situation, functioning or non-functioning carcinoma, incidental or symptomatic due to the mechanical symptom. So far, after desperate housewives, if we are looking at the situation of the surgeon, there is the desperate surgeon. Also because the surgeon has to put himself or herself in the setting of the roadmap of the patient with advanced neuroendocrine tumor where the protagonists are many. And looking at the hope occur, we have to establish very well, or as much as possible, which point the surgeon should be. What usually happens, despite we declare that our approach is a multidisciplinary team, is that we do not work together usually. The patient is referred to the surgeon, and thereafter the surgeon applies therapy, and then the patient was sent to the nuclear doctor and maybe to the oncologist. Or it can also happen that whenever the oncologist sees the patient at first, he treated the patient, then he tried to send to the nuclear doctor, and then he arrived to the surgeon. Or again, nuclear doctor make the imaging, then he treats the patient, and then the patient was sent to the surgeon, and then to the oncologist. And everybody thinks of himself that he is the strengther, or is the targeted, or again, is the clever one. How is possible to find the rule? I would like just to remind you that there is the second law of thermodynamics, where over the time, the energy decreases. And if we try to apply the second law to neuroendocrine setting, we have to say, or to remind to us, that the higher is the first bound, the longer probably is the survival. So far, it's very important to establish the responsibility of the right order of different treatment in a multidisciplinary approach. So there is a new concept already stressed, that is the team, but what is important is that the team discuss in advance the possible choices. That means we have to establish the strategy before moving to treatment choices. And the conditioning factors are usually the presence of symptom, if any, the stage of the disease biology, that means aggressiveness, and the probability of the results. For sure, there is a need of surgery whenever we have a mechanical symptom on biliary tree or on GI tract, according to the different sides of the tumor. And the surgeon might apply resection or bypass the patient according to the stage of the disease, and we are looking thereafter which are the possible rules. So far, whenever a mechanical symptom exists, probably the surgeon is the first protagonist. And the surgical weapons are, we have already mentioned, biliary or intestinal bypass or resective surgery with the proper lymphadenectomy. And we have also to remind that it is not, the therapeutical choice are not just in the surgeon's hands, but we can use intra or postoperative ancillary procedure, such as chemoembolization, radiofrequency ablation, or alcoholization according to the number of the lesion, above all in the liver. Unfortunately, we are in the setting or non-art state for debulking. Because in general, what we think in order to justify our debulking procedure is that the lesser the burden, the better the response to further therapies. And this is true because whenever radiometabolic therapy is applied, the Queckburn study show quite well that the less is the burden of the disease, the better is the response. And on the other hand, the study that was already mentioned as regard the pyramid on application of octreotide LAR versus placebo showed quite well that the less is the burden in the liver tumor load, the better is the response to octreotide LAR, whilst when the burden is more than 20%, we do not have any difference between placebo and treatment. However, we do not really know whether or not this is an achievable result, so justifying the debulking, or is just a disease favorable stage at diagnosis. So we are still in a non-state art of the debulking. For sure, the higher is the aggressiveness of the disease, the poorer the results. And this is true for the pancreas in our study, when you can see that differentiation of the disease as well as an high Ki-67 at diagnosis means a poor prognosis as at multivariate analysis on survival. And again, there is another rule, and this is a state-of-the-art, that no advantages for debulking if an extra-abdominal disease exists, since the identification, you can see that the survival curve is definitely worse whenever extra-abdominal disease exists, as well as the liver burden is more than 5 mets in the liver parenchyma. So trying to summarize the possible tables of the law for debulking, we can say that the first law is primum non nocere, because we have other kind of therapy. And in the second step, we have to say that the diagnostic are the real driver of the therapeutic choices. Firstly, the pathologist, because we do not need just the diagnosis of a neuroendocrine carcinoma, but as already Professor Kroper stressed, we need also to know which is the aggressiveness of the disease. And so far, we have also to receive by our referral pathologist the information on Ki-67 proliferative index. And the second step, as Anders already stressed, is the nuclear doctor, because we have to know whether or not somatostatin receptors are present in order to have a further possibility to target them. So whenever the clinical scenarios shows an aggressive biology of the disease in G2 tumor or G3 tumor, probably the place for the first protagonist as doctor or referral doctor is the oncologist. If we are dealing with a diffuse disease, the therapeutical choices probably are based on receptor status, as we said, but also on general condition, patient age, and renal function, and the ball, sorry for defining the patient as a ball, passes between oncologist and nuclear doctor. But whenever we have an abdominal disease with the unresectable liver mets and resectable primary tumor, probably the therapeutic choices must be based on receptor status, because their presence will dictate the possibility to have a further therapies after surgery, the general condition of the patient age, the renal function. But on the other hand, from surgical point of view, we must distinguish midgut or pancreas origin of the primary tumor. For midgut, as being already underlined by Professor Grommas, probably there is a definite place for debulking. Unfortunately, as a surgeon, we did not plan yet a randomized clinical trial. These sentences are based on the place of debulking is based on retrospective data from the Uppsala series, when you can see that the survival doubled whenever the surgeon was able to resect mesenteric in the setting of unresectable liver mets. And this was confirmed by the GIVI study, where again you have a double survival rate when the primary is resected or was resected, despite the presence of unresectable liver mets. This is true also even if the patient was asymptomatic at the time of diagnosis. And again, this data was confirmed in a larger series, again a retrospective series by the UKNet, where you can see that whenever the primary was resected, the survival rate was the best in respect to the other situation when a bovable pass or no resection were performed. However, I have to say, despite I am a pancreatic surgeon, that in the pancreas, disadvantages is not shown. And so far, if we are looking at the possibility to debulk a patient with the neuroendocrine tumors in the pancreas, in the presence of unresectable liver mets, we have to be aware that we do not any justification from the study. But if we think as regard debulking, in my opinion, we have to apply a pack of debulking procedure. That means not only surgery, but also to apply radiofrequency ablation, transarterial chemoembolization, in order to make any sense of surgical palliation in order to move to, for example, radiometabolic therapy. So we have to try during my talk to establish the golden rules, which are definitely non nocere. We have to wait for the information coming from both the pathologist as well from the radiologist. But what is important is to discuss in advance the whole strategy. Otherwise, despite we have established the rule for the evidence-based medicine, since we are in most instances in the series of retrospective unfiltered information, we will be in the ground floor rather than in the top of the scale of evidence. And what I have also to admit is that in this setting, speaking about surgical procedure, we have still a long way to go. Thank you very much indeed for your attention.